Well, I want to thank everybody for being here today on a beautiful Friday afternoon, and I really do appreciate your involvement in telemedicine. And the other thing that I want to say is I'm really excited about this data. This is data that we've not presented before, but it will be coming soon to a journal near you. And so to begin with, I just want everybody to know that I have no financial things to disclose, but I wish I did, because I'd be way richer than what I am right now. Grimes and I were talking about, with all this money that we have in neonatal intensive care and taking care of babies and, telemedicine and so forth, I think state employees should get a piece of the action, right? Yeah, so, but unfortunately it doesn't happen. I'm excited about this data, so thank you very much for being here today on a Friday afternoon. And if you don't like what I've got to say, you'll definitely like the next speaker, that even though he's really ugly, he's really done a lot of really good things. Regionalization is important in Arkansas. We can save 1 busload of babies a year. But why don't we do that? There are probably 3 reasons. I've seen all kinds of reasons. Money and prestige are probably big things that people say, but that all relates to, number one, is a lack of resolve. We have got to resolve that we are going to take care of babies. Unfortunately, babies do not fill out satisfaction surveys. When they hurt, they don't get to write, well, I was in pain and nobody took care of me. Number 2, there's a lack of knowledge, I think, in general, about the importance of regionalization of neonatal intensive care. And the third reason is that in our state, we have had to date, and hopefully that's changing, thanks to the excellent work of David Grimes and excellent work of Medicaid, David, your involvement with them, and Tina, thanks to a lot of people, that will come to pass. It will probably be mandated by the health department on a voluntary basis, hopefully within the next few months, but it probably won't be mandated with teeth for another few years. But we hope that there will be good regionalization of care in Arkansas. Having said that, most states, only 7 states now, as of the latest data, show that babies deliver in an appropriate level of care. That even though Arkansas does not have designated levels of care, many states like Arkansas, although they designate levels of care, the babies don't go there. So without teeth in these regulations, that's a problem. So if we look at infant mortality at Arkansas and the rest of the United States, David, you've seen this like ad nauseum, right? So I don't think there's any reason for you to go over it. But if we look at the infant mortality rate in Arkansas, it's higher than the rest of the United States. But I want you to look at the trends a little bit and look particularly at the dip that you see there. And I want to at least take a stab at trying to explain why we may be seeing that dip, or why I think that we're seeing that dip. If we look at some of the infant deaths and rates in Arkansas and the United States, Arkansas has a rate of about now in 2009, and actually it's even gone down further. The last that I saw, I think it's 7.1 neonatal deaths per 1,000 live births. The United States rate was 6.4 at that time. The neonatal rate in Arkansas is actually just slightly above the national average at 4.2. The post-neonatal mortality in Arkansas is 3.2, which is higher, much higher actually than it is in the rest of the country. Let me just kind of go over some of the causes. There are basically three basic causes. That shows that I didn't take speech in high school, right? So about 2/7 of the causes are related to congenital defects. One of the things that we could do with that, we could put folic acid in flour, make it more readily available. There are things that we could do to decrease the number of congenital anomalies. The plurality, not the majority, but the plurality are secondary to preterm delivery. Arkansas ranks 30th in the country in neonatal mortality, and although we're better in that area than we are, say, in postneonatal mortality. We still have a ways to go, even to get down to average. And 2/7 of our deaths are due to postneonatal mortality. If we look at the neonatal contribution, almost all of these are babies less than 1.5 kilograms. If you look at that, 190 out of the basically 210 births or so that were delivered were due to very low birth weight causes. So that is by far and away the largest majority, and this is the part that I really want to concentrate on. Well, what can we do? It's difficult to influence congenital defects. Just for fun, how many women here are of childbearing age? Raise your hands. Okay. Could be. Okay, now of those, how many are taking folic acid? Okay, and that's my point. Okay, if you look at pediatric residents, none of whom have had any sterilization procedures, only 1/3 of pediatric residents take folic acid. Now, if anybody ought to know about the importance of preventing neural tube defects, it should be a pediatric resident who takes care of it. And additionally, it's hard to get people in sometimes for prenatal testing, and oftentimes the people that we have that are doing prenatal testing, the ones that we're most concerned about, come in for either late or no prenatal care. It's difficult to influence postneonatal mortality. We have initiated a lot of programs, particularly the Back to Sleep program. We've looked at, Mary Aikens has done a wonderful job with the Injury Prevention Center at preventing intentional as well as unintentional, particularly unintentional injuries. But the important thing is the plurality, that 3/7, we can influence that. We can influence the survival of very low birth weight neonates, and that's the biggest contributor of neonatal mortality. And we can do that through regionalization of neonatal intensive care. Now, when we look at our experience in Arkansas, and this is, by the way, this corresponds very nicely with national data. 8 years of data, 2001 through 2008, 320,000 deliveries, and levels of care were defined by consensus, which means that I decided who got to be levels of care. So that's a criticism, a valid criticism of the paper. But I think there actually was pretty good consensus on who was and who was not, and it was devised on, the levels of care were designated based on the American Academy of Pediatrics recommendations at that time. If we look at the Arkansas story, and if we look at deaths, is this a pointer? Mm-hmm. Can I point? Okay. Let's see now. There it is. Well, okay, hold on just a minute. There we go. Can you all see that? Okay. If we look at babies under 1,000 grams, okay, and if we look at where these babies are delivered, if they're delivered in a level 1 unit, and a level 1 unit we defined as being a unit without a neonatologist, okay, the mortality for babies that weighed less than 1,000 grams or less than 28 weeks was right at 34%. If we looked at babies in this weight range who were less than 1,000 grams and less than 28 weeks that delivered in a level 2 unit, which we define as having a neonatologist but not having a board-certified perinatologist or all the subspecialty care, which were basically UAMS and a few of the other nurseries around the state, the neonatal mortality for babies in this weight range was right at 22%. If we looked at babies that delivered in a level 3 unit, which was a unit that had access to perinatology and subspecialists, the neonatal mortality was about 11%. That's basically 3 times the risk of dying. The relative risk of dying is right at 3 times if you deliver in a small nursery, 2 times if you deliver in a nursery with a neonatologist, but not much else, and your relative risk, of course, is 1 if you deliver in a true level 3 institution. Now, if we look at the other levels, if we look at the other birth weights, particularly birth weights between 1,000 and 1,500, they're pretty much the same across the board. We didn't really see much difference. And if we look at babies that are less than 1.5 and less than 32 weeks, that's this number. You can see that there's a slight difference here, but it was not very significant. Okay, but if you look at babies between 1 and 1.5 kilograms, it was basically the same right across the board. Okay, so that is how we. This was this bar here is the total babies less than 1,500 grams. So that's the Arkansas story. So the question is, can telemedicine be used to affect place of delivery and thereby decrease infant mortality? Can we do this? Well, telenursery has an infrastructure, and the first thing that is required is vision. And I have to look across the room at Tina and Curtis Lowry and many of the other people who are pioneers in this, and they have been heroes in my mind to have the vision to connect various areas of the state with telemedicine. The second thing that is required is 24/7 service. Okay, that means that any physician or any healthcare provider needs to be able to ring up with telemedicine the healthcare provider in the higher level institution and ask a question and get a reasonable answer. The third thing that's required, of course, is connectivity. We've got to have the superhighways. In our case, it started out as a result of concerns over bioterrorism, because T1 lines were established throughout the state in order to connect all the emergency rooms in case of a terrorist attack. So this connectivity was utilized to our advantage for telemedicine. The next thing is just fantastic IV. We are so fortunate to have excellent IT support. And finally, we were very fortunate to have the financial support of Medicaid. They also had the vision, and they're also to be commended for this wonderful work. We were fortunate enough to receive a Touch grant, which was a grant that was funded by the Center for Medicare and Medicaid Services, and it allowed us to have an evaluation piece, and it was a novel addition to any of the patient-centered outcome research protocols. And what we did was to look at 9 months before and 9 months after a telemedicine intervention, and we did this with the Touch group. And what we did as far as interventions were twice weekly OB census rounds, where we just dialed up the nurseries. Many times they weren't there, many times they were, but we were always there. We had continuous 24/7 OB consultation. We did telenursery rounds 3 times weekly to connect with our nurseries around the state. And again, we had 24/7 neonatal coverage. We had educational conferences that were sponsored by both obstetrics and pediatrics. And finally, at the end of this, we had social support, which is the Angel Eye, which had been very successful and very well accepted by many of the mothers and families who are able to follow their babies when they're in the nursery from home. Well, what we found was the main group we were after was this group right here. We were looking at very low birth weight deliveries, and we did not want them to deliver in these nurseries. These are the nurseries that had no NICU, but did have telemedicine. There were basically 4 nurseries that we identified. Those were based on volume data that had a bunch of very low birth weight deliveries. And as you can see, we basically cut in half the number of deliveries in neonatal intensive care units, very low birth weight neonates in nurseries without NICUs. None of the rest of these changed. If they didn't have telemedicine and didn't have an NICU, they had the same number of deliveries before versus after the telemedicine intervention. If they had telemedicine in a NICU, there was no significant difference. No telemedicine in a NICU, there was no significant difference. UAMS, there was no significant difference. But this was the group that we were really targeting in this intervention, and we were very successful in decreasing the number of very low birth weight deliveries in those units. Additionally, even though this was not significant when we looked at this, and we looked at it from here to Sunday because it seems like it would be significant, we decreased the number of deaths before and after telemedicine. Okay, and if you looked at the babies that had telemedicine without an NICU, there were 2 deaths compared to 6 the 9 months before versus the 9 months after. Okay, none of these figures, because of the small numbers, were significant. Okay, but here's the kicker. The statewide mortality 9 months before this telemedicine intervention and 9 months after the telemedicine intervention fell significantly. You remember that graph where there was kind of a dip, and this is where the dip was. Now, it very likely could have been due to a number of other factors. I'm not saying that it could not have been, but I am saying that we had a significant change in the place of delivery of these very low birth weight infants. We had a decrease in the number of deaths. And one of the concerns that I had was that we were shifting deaths from nurseries that had no NICU to, say, UAMS or larger nurseries that did have an NICU. And this data, in my mind, proves that at least we certainly did not shift deaths from one nursery to another. And I think the effects of this telemedicine have been felt statewide, and I think a big part of this is the combined effect of obstetrics and neonatology working together, the financial support of Medicaid, and the backup of the health department that has provided us with much of this data. Just a couple of things for those of you that may be interested in doing this. If you look at the nursery sign-ons, you can see that the sign-on percent in OB was not as high as we would like, even though a lot of these people did not sign on every time. They would sign on intermittently. The number of nursery sign-ons with our touch program actually increased throughout this, but it took a long time to really get the numbers, particularly in the nursery, to where we wanted them. I think that the OB did not have as much effect. The OB part of the touch program did not have as much effect as the nursery part of the program, but I think that the two were clearly synonymous, because I think that when the pediatrician tells the obstetrician that, no, we don't need to be delivering these small babies here, that has an effect, and I think that's the effect that we were seeing, because this was basically an OB study. So these are the lessons learned from those of you that are interested. Initial installment of this required face-to-face contact. We've been traveling all over the state. We've got to include all stakeholders in this: nursing, administration, and physicians. The people that we were working with the touch program had quite a bit of experience due to the Center for Distance Health, and they helped us quite a bit to get all these important players to the table. Revisitation is required. You know, this is not a project where you can just say, if you want to decrease mortality, you can't just say, well, we're going to do this and then we're going to go right off into the sunset like the Lone Ranger and never have to worry with it again. It does not work like that. We have to continue to revisit, call on the telephone, and we would do that with each of our nursery sites about once a quarter. Not all hospitals will buy in. We asked some hospitals if they wanted to participate, and they said no, thank you. And the other thing is, this starts slowly. It takes patience, patience, patience. It will not work in the first month or two, okay? It's going to take at least a year, and oftentimes 2 to 3 years. With our Educational Peds Place Conference, it's become very successful. I think OB is the same way. It started out with basically one guy, Mesco, in Mena, Arkansas. And, you know, it really has now expanded. OB has expanded to surrounding states, and Peds Place has done the same thing. Many of your partners will not buy in either, and it is very important that a champion for telemedicine be there, and you guys have probably heard this ad nauseum. Patience, patience, and patience is important. Remember what's important, that the patients, the PATIENTS, are the important thing. Be sure to have it patient-centered. The center must be accessible, and ICT support is critical, and 24/7 coverage is absolutely critical for inpatient coverage. Conclusion: telemedicine can be used to decrease infant mortality. Its use requires patience, infrastructure, and physician champions. For the future, I think the future is really bright for this technology. We've developed a telelaryngoscope that we're very excited about, a possible private-public partnership. We're looking for funding, so if anybody's interested, we've got our hands open. I think it can enhance regionalization in many other areas besides just neonatal intensive care. And tele-NICU, looking at heart rate variability and doing ventilator adjustments. There's a lot of things that we can do with telemedicine. We've only begun to scratch the surface, embedding an academic practice into a community practice. And by the way, it's extremely important to remember that that train has to run both ways. The community docs, believe me, know every bit as much as the academic docs, except they know more, because they have to deal with all kinds of problems and situations. They have been an invaluable partner in this process. The future is also can be used internationally. Those electrons travel very fast. We've used it to help facilitate a Helping Babies Breathe program, which is a neonatal resuscitation at Namyaga Mission in Zambia, Africa. Infant mortality there is about 69 compared to 6.9 in the United States. Okay, any questions? Those are my two kids who are living at home. Here's the 13-year-old, and she used to be nice. And they used to like each other. I just got back from a trip from Dallas where we went to a water park there, and that was quite an experience. It was not a good experience, but it was an experience. Any questions or anything?
We have a mic in the middle if anybody has any questions. Sure.
Can you just talk a little bit about the OB rounds and how you engage them? I mean, are they scheduled at, I think you said they're twice weekly?
Really good question.
Is that all at the same time, or is it specifically with that, with a specific hospital?
For OB and neonatal, that's a really good question. I didn't expand on that very much. I think it's very important to have short, frequent contact, okay? And that's for a rural state. If you think about it, you know, we're talking about, you know, a small number of patients in each nursery being relatively small. It's only when you take them together that you get adequate numbers that you can really see differences here. And so we think that it's very important to have that frequent contact. We started out with OB doing 3 times a week, and we had to change it back to 2 because we didn't get good participation. And we said, look, will you come on more frequently if we do twice a week? And they said, yeah, I guess so. And with OB, it was not as successful as it was with neonatology. Neonatology and OB both met early in the morning. OB met at 8, and I think we do meet at 8:15. We are still doing that, and that continues, and it's been a good thing for us. What we did was to say, hello, how are you? What's your census? Can you accept back transports? Do you have any questions or any clinical issues? And it's interesting. We have a clinical issue that we address once or twice a week probably, where we want to look at the baby or look at an x-ray or just discuss it face-to-face with the referring doc. And that really helps out a lot. The reason I think that neonatal telenursery rounds works better than tele-OB is because there are many visual cues that we can get from looking at a baby, whereas looking at a mother, we don't have those visual cues. On the other hand, with OB, it's very successful using ultrasound because that's visual. So remember that what telemedicine adds is the visual component. Now, having said that, I think that there's a huge difference between talking to somebody on the telephone where you have only audio and talking to them over telemedicine where you have the audio and visual. And, you know, psychologists tell us in looking at functional MRI, if you get visual images in your brain, that has many more connections than just auditory. And we all know that. It's more fun to look at television than it is radio. Radio got outdated when television came along. Duh. So, you know, having that face-to-face interaction I think is important, but it's particularly important in the nursery where we can actually look at a baby. Because when somebody tells me, well, their baby's breathing fast or he's breathing funny or his eyes look funny or his face looks funny, well, you know, over the telephone, I can't tell you very much. But if I can look at that x-ray and look at that baby's face, well, then I can say, yes, this looks like trisomy 21. This looks like Down syndrome. I think you need to talk to the family and tell them that's what you think it is. Because I can tell you that I personally do not want to go in and talk to a family that has Down syndrome, which is a collection of minor anomalies, without having one of my peers agree with me. Think about it. If you're a family practitioner in Searcy, Arkansas, in a small town in Searcy, and you have a baby with possible Downs, you're going to want one of us to look at it. And that's the beauty of this. Pardon?
So thank you.
Oh, you're welcome.
Yeah, I noticed you mentioned that you had a couple sites decline to participate in that, the touch program, and I was wondering if you had any kind of feedback as to what the reluctance was, and maybe how people could strategies they could use to address that as they're creating programs of their own.
Well, that is a really good question, David. First of all, they were stupid.
Right.
Because, really, the connectivity was free. It was furnished by a grant. But, of course, they were looking down the line and saying, well, what's this going to cost us and how much time is it going to be? And I think the other thing that we did, we presented the data to them, what we could do and what we could not do. We cannot be there for a neonatal resuscitation, but we can assess a baby with congenital anomalies and maybe not transfer the baby. We can avoid transfers, and I don't have this data on this thumb drive, but we actually were able to avoid transfers using telemedicine. So explaining the advantages of it, I think, is basically what we did, and we did that face-to-face. Having said that, we probably we now have 25 units out in the state, and we've probably had 2 nurseries. So it's been 2 nurseries have declined. So the vast majority have been accepting of this. The other interesting thing is that funding for this is oftentimes provided by local donors. Because if a donor can donate to Arkansas Children's Hospital, they think, well, they're doing a great thing. But if they can donate to Children's Hospital that will directly help their community, that is a really great thing. So if I'm a donor in Russellville, Arkansas, and I want to have a telemedicine unit in my nursery, that's a great way to spend my money if I'm going to do that, or a great project. So that's a good question. And basically, if they don't want to do it, then we just assume they didn't. It's a lot of investment for us and for them, so it's okay if they don't want to do it. And they may have a relationship, like one of the nurseries in Jonesboro has a relationship with one of the Baptist nurseries. And so they didn't particularly want to connect with us. So that's okay.